All right. Good afternoon, everyone. Welcome to the radar seminar. I'm going to get rid of something logistic because I'm remembering it at this moment. So when you have questions, please drop them in the Q&A part. I think your chat button is disabled, so please put them in the Q&A. We'll get them. If they're going along, we may get answered during the talk or at the end, but please put them in as they come to you so you don't lose them. We're very excited about this. So with that, it is my absolute pleasure to introduce Dr. Habecker. I told him this was going to be very short because everybody knows Patrick. Patrick is got his PhD from UNL in 2017 in sociology and a minor in what we would call SRAM, or survey research and methodology. He is just a linchpin of a co-director in the Longitudinal Network Core. And he has, I just can't praise him enough for the work with the regional health cohort, what used to be formerly known as the rural health cohort. And I think this will be the data that he'll be presenting a bit on today. And I've been touting this as a big reveal because there's a lot of data here that a lot of us don't know about, but Patrick does. And I am not going to keep us waiting any longer. So please join me in welcoming Patrick. And thank you so much, Patrick, for presenting today.
Thanks, Rick. Thanks for having me. Nice to see everybody. Well, be here for everybody today. Not in Nebraska today, unlike I typically am. I'm actually in downtown Philadelphia, shout out William Penn atop of City Hall, here for the American Association of Public Opinion Research Conference. But absolutely delighted to take a break from that to talk with you all today about some of the work that we've been doing at the Radar Center. So what we want to do today, or what I would really like to do, is talk about sort of the first stage of this project. We called it the RHC. And essentially what it is in this early stage was to try and talk to about 600 people in sort of the Great Plains, more specifically Southeast Nebraska, who are currently using drugs in a variety of different ways and learn something about them. Right? But before I get too deep into that, a handful of acknowledgements are in order. The first one, where do we get our money? Thank you very much, NIGMH. And we're very grateful for their funding for this. And this is only possible because of their work and their funding, but also because of this entirely gigantic team that has contributed to making this work. You know, the PIs, the staff, literally everybody who makes this click is the only reason this works. And in particular, I'd like to take a second to thank the interviewers, the people that day to day are interacting with folks, treating them well, having a good environment, and really just putting their best step forward every single day. And, you know, as we've been doing these seminars for the past few years while the Radar Center's been around, it's always been neat to see, like, people come in with their labs and they show off the whole lab. And we don't necessarily have a lab, but we have a crew. So this is from some of our early deployments, interviewers and field staff, people who are working to make this thing click. As we moved through into COVID, we switched to very briefly just sort of handing out booklets in a parking lot under a tent when it was bitterly cold. You know, celebrating some hard-won milestones all the way through, and sort of recertifying and training. It's just my name on this seminar today, but none of this is possible without absolutely everyone. I'm really looking forward to getting some of this into publication and having these folks be part of that. So, acknowledgements aside, let's talk a little bit about what we're doing here today. And the goal of this project was to find and interview at least 600 people who are currently using drugs in Southeast Nebraska. Interviews are almost always self-completed using a laptop. We have some pieces that are proctored, but for the most part, it's the participant working through the survey questionnaire in a private space on their own with someone outside who can help out if they need. And the goal was for folks to come in, do an interview, and then we try and enroll them in a longitudinal study where we then come back around and interview them every 6 to 9 months, as long as we sort of have the funding to keep it going, and as long as participants are still willing to come in and talk to us. So today what we're going to do is we're going to talk about some basic findings from this first interview period with our first 600 participants. We just recently hit that milestone. And so today is going to be very descriptive we're going to talk about sort of characteristics of the participants in aggregate, demographics, substance use profiles, overdose experiences, physical and mental health, adverse childhood experiments, and experiences with substance use treatment services, and sort of wrap that up with some concluding observations. We're keeping it light for a couple of reasons, but one of the big ones is that this is a work in progress and we are open to collaboration. We are open towards the next step. And this is a way for us to sort of stop, pause, see where we're at, and then move forward. So a couple notes about how we went about this: eligibility, recruitment. How did we get to this data in the first place? Eligibility itself is fairly broad. Participants needed to be at least 19 years old. By the way, if you're not from Nebraska or haven't spent time here, that's the age of majority here. And then participants needed to use either an illicit substance other than cannabis or alcohol, or use prescription medications in a way other than prescribed in the past 7 days. So we weren't looking for on-entry eligibility having used substances in the past, or even earlier in the year. We really were looking for folks who were fairly currently using some form of substance beyond cannabis or alcohol to sort of make our eligibility. So the second piece then is recruitment. How do we find these folks? And for us, the core driver is respondent-driven sampling. If you're not familiar, this is a technique that sort of samples or recruits people along existing social network paths. So the idea is you start with a small handful of people who you sort of recruit or approach directly, or maybe they approach you through another means, and we'll get to that in a second. These folks complete the interview and they get paid for that. We are compensating $40. And then they get coupons that they can pass to people who they know who are eligible for the study. So these coupons are pretty basic. It's really just contact information. It's a little bit of additional pieces to it. And then if somebody decides to come in and take our survey with the coupon and they're eligible, they complete the survey, the referrer gets an additional incentive, typically $10 per coupon. And in many settings, RDS would start by meeting with local organizations who are already in touch with people who are currently using the drugs. So a lot of studies you see this with start with maybe a local syringe service program, harm reduction organization, or an overdose prevention center, some sort of typically a non-medical facility, a non-law enforcement facility that already has a connection, right? Unfortunately, there really aren't very many of those in Nebraska. And so we actually had to start cold. So we started recruitment cold, just using flyers and hoping that someone would sort of see that and take the risk to come and talk to us. But from there, these recruitment chains have sort of led to now over 600 interviews being completed and people sort of coming in the door and being curious about what we're doing and being willing to come talk to us. So RDS isn't the only network sampling method. There's a handful of these out, but RDS has a couple advantages that we like. One is sort of this dual incentive system. So participants get incentives for completing an interview. They also get incentives for passing those coupons to somebody who's eligible, who they think they're eligible within their existing social network. It's helpful for us because it sort of drives on that propagation of essentially recruitment asks. The second part, though, is that RDS is peer recruitment and not peer identification of their peers. And what I mean by this is that some other network study frames, most of these are not considered usable anymore, would ask participants to provide the researcher with a list of names of who they think is eligible or their contact information. And RDS doesn't do that. By giving out coupons, the researcher never actually knows who those coupons go to until that person decides to come in and talk to us or decides to take a chance on us and schedule an interview. So this means that those potential participants really stay completely anonymous. Their right to refuse participation is anonymous. We don't know who they are. We don't have a sample frame. We don't have their phone number, their address, any of that type of information. And I think this provides a lot of security for those folks who may decide if they want to come in or not. And the other thing that adds to this is that they get the chance to talk to their peers, the people that they know outside of the researcher's influence, to ask, well, what was the interview protocol like? Did they treat you well? Was it the cops? Was it a trick? Was it a trap? Did they actually give you money at the end of the day, right? So I think for us, where we were starting really cold, where we didn't have a lot of contacts, where we're in a state that has almost no harm reduction infrastructure, that has no real outreach other than what's associated with treatment, medical services, or law enforcement officers. This was a really key piece for us. And this has been our primary driver for recruitment. So our goal, as I said, was to begin recruitment and try and get to at least 600 people and then sort of iterate that over time. And we initially started this in 2019, but were halted by COVID-19 outbreaks and sort of that general suspension of human research. But we started again in June of 2021. And it took us until January of 2023, starting fresh, starting back at zero, to reach and interview over 600 people who are currently using drugs off that eligibility criteria. Now, during that year and a half, people that were interviewed first have started to roll through their 6 to 9 month time period, and some are even moving through their third time period. So what we're talking about today is sort of that first interview over this, 16, 18 month time period. But for some folks, we've already talked to them twice and even 3 times as well. But keep in mind that this is that very first point of contact for us that we're talking about today. So another comment before we sort of really get into sort of some of the results from participants is a quick note about interviewer workloads. We initially thought when we were planning this out that this was one of those things where research staff, research facilities would be able to sort of maybe take 2-3 months, do a bunch of interviews, and then go back to our regularly scheduled work. And that immediately became apparent that that was not feasible. And so we've shifted over time towards having really dedicated interview staff. And even then, we've had to sort of shift from where early on people might be doing 4, 5, maybe 6 interviews in a day, to really paring that down, where interviewers today are typically only doing 2 or 3 today, because these are long interviews. And even though it's largely self-administered, it's a very high tense, well, not tense, it's a high focus task, right? And there's all sorts of potential for things to shift, move around. And we've had to think about what is our staffing needs. And I think for a period of time over this, and so if you're thinking about doing a study like this, I really advise you plan for more staffing than you think you're going to need. It'll pay off in dividends. And the only reason this is possible is because early on we decided we needed more staff, more full-time staff whose job was to interview. And so all the work that follows is possible because of that. So I encourage you not to undershoot this. So let's start thinking about what we learned about some of these folks. So first off is that the average participant, or their average age, is about 41 years old of the people that we've talked to out of the 600. We have a pretty solid range on this. A single standard deviation is about 12 years on both sides of that 41, but our youngest is 19 and our eldest is 72. So we have a pretty good spread of people who, remember the eligibility, have used some sort of substance, either illicitly or using in a way not prescribed in those sort of past 7 days. We have an interesting sort of sex split where 52% are identifying as male or man and 42% are identifying as female or woman. A lot of studies tend to be way more male heavy or man focused, and we have not quite parity, but close to this. 77% of participants, when asked about sexual orientation, say heterosexual, 12% say bisexual, and then there's a handful of categories that are all less than 3%, but I didn't list them all out here. We provide a range of options, but these are the 2 primary ones. 77% of our participants say they are not Hispanic or Latino, and 10% say they are Hispanic or Latino. About 13% of people either skipped or refused to answer this question. And when we asked about sort of the census standard race categories, 41% of participants selected white alone, 22% selected Black alone, 11% selected American Indian or Alaska Native alone, and 5% selected Native Hawaiian or Pacific Islander alone. We didn't have anybody that selected Asian as a standalone category, but we did have 11% pick multiple of these race categories in a variety of different combinations. And about 11% of people just were not interested in this question, either skipped or refused to answer it. Think about education and entertainment. 16% of our participants never finished high school. 44% had finished high school but didn't move on to any form of college, and 30% had some sort of college degree. This is typically a range from 2 years, associate, sort of technical or trade. And then only 9% had progress to either a 4-year or a professional degree beyond that. So by far and away, our most common educational attainment was finished high school, with not many going beyond to more formal degrees past that. And the reason for this is, as we'll come up in the next couple slides, is we ended up recruiting a lot of people who were unemployed. So 46% of our participants were currently unemployed. Only about 18% had a full-time job. 10% had a part-time. 17 were on disability, either permanent or temporary. And then there was a small mix of students, retirees, or a few other tiny categories that typically had less than 1%. But most of our folks that we were talking to were not working full-time or not working part-time. And this is shown in the income, right? So 44% of our participants reported less than $5,000 of household income in the past 12 months. 27% reported $5,000 to $20,000, 13% reported $20,000 to $50,000. Only 4% of our participants reported earning more than $50,000 a year for their household as a whole. And so we tended to have recruited participants with lower education levels, lower income levels. And then when we asked about experiences with homelessness and unstably housing situations, we had a huge chunk of people that had experienced that in their life. 71% of our participants had been homeless or unstably housed in the past. 48% had been homeless or unstably housed in the past 6 months. And 33% were currently homeless or unstably housed when we first talked to them at that moment of the first interview, right? So even for our neck of the woods, this was perhaps an unusual sample composition to a little bit. And we'll talk about this further down the line. So thinking about what types of social supports did these folks have? We asked a series of questions, really just trying to focus on, are there folks that these people can sort of rely on and talk to? So 89% said there's at least one person that they can confide in, and 87% said there's someone in their life that they can get emotional support from. 84% say there's at least one person that they can trust, and 88% say there's at least someone in their life that makes me feel worthwhile. And then for more sort of task orientation stuff, there is someone that would come get me if I was stranded somewhere, 84%. And 65% said there's someone who would give me financial assistance if I needed it. And 67% said there's someone who can help me fulfill my responsibilities if I'm unable, right? So folks do report at least one person in their lives that they can get a range of these things from, but we do see it drop down a little bit for when it comes to financial assistance and helping them fulfill responsibilities. We also asked similar types of questions about how they feel in their community, and that was left somewhat vague. So thinking about what does their community look like, how do they see themselves in it? And so in the past 6 months, how often have you felt that you belong in your community? 38% said often or always they feel that they belong, but 30% also said that they never or rarely felt that they belong there, right? 31% said that they often or always felt out of place in their community, whereas only 35% said they never or rarely felt out of place in their community. When asked if they felt unwanted in their community, 20% said often or always to that, and 51% said never or rarely. And again, this likely crosses heavily with some of the other things we talked about, as sort of that experience of being homeless or unstably housed in the region. Now, one of the primary reasons that we started this study and to sort of look at it was to try and understand patterns of substance use at this local level. Nationally, statistics we can get from things like the National Survey of Drug Use and Health, and they can provide state and somewhat sub-state estimates as well, often with considerable delay. But one of the things we wanted to get a handle on was, what are some of the substances folks are using in our local area, and what does this look like? So this table shows non-injection substance use. So this is sorted by route of administration. So these are substances that are consumed in a way that's not involving an injection point, a syringe, or a needle. And we asked about a handful of substances, and I have a few here for you. This table takes a little bit of sorting, so I'll just walk you through. We have a list of substances on the left. So marijuana, cocaine, ecstasy or MDMA, amphetamines, and methamphetamine. And yes, by the way, participants often do know the difference between the two and can talk about that. Benzodiazepines, opiates, opioids is sort of a larger catch-all category. And we talked about heroin specific. and then something else. If we look at the vertical bars moving across, this is a frequency of consumption of these substances, typically in the past 6 months. So they could say never, they could say less than 1 month, once a month, once a week, 2 to 6 times a week, once a day, 2 to 3 times a day, or 4 more times per day. And so I've added the gray vertical highlightings to sort of show people on the left, those who have never used these substances, what that estimated proportion is. The next block of white is sort of the people that are using once a month or less than once a month. The second gray bar shows the folks that are using weekly or more than weekly, but aren't quite up to a daily pattern. And then that far right block of white is our daily patterns, right? And so if you look through this, there's a couple of substances that are really fairly rare in a non-injection route of administration in our participants, right? So very few people have reported using heroin in the past 6 months. 87% in fact say they've never used heroin in this time frame. Opiates and opioids are fairly low as well. 63% saying that they've never used these. 72% say never used benzodiazepines in this time frame. Ecstasy is a fairly rare one as well. 69% saying they've never used ecstasy or MDMA. But we do see more or higher levels of use as far as marijuana. 17% say they've never used it in 6 months. Cocaine, 49.5%. Amphetamines, 53%. And methamphetamine, only 22% say they've never used this in the past 6 months. And for a lot of these substances, where we see the bulk of sort of this use falls in sort of the monthly and the weekly range, right? So if we look at cocaine, for example, 17% of participants were saying this is something they use less than once a month, or 10% saying they use it monthly, basically once a month, and 8 to 6% saying that this is something that occurs on a weekly basis, but not necessarily a daily basis. However, do note, right, we've got this subset of folks, 7% of people who are using at least cocaine daily, and 3% of them saying that they're using cocaine 4 more times per day, right? Methamphetamine is another really large use category here for us, with 17% saying that they're using this 4 more times per day, 17% also saying they use it 2 or 3 times per day, and 5% saying they're using once per day. So there's a high level of methamphetamine use and a lot of use patterns throughout that given day when reported this way. So let's see if I can do math offhand. 34% says using 2 or more times per day, 29% or 39% overall at daily use levels. And it sort of falls down a little bit. We still see 7% of folks saying they use less than once a month, 4% once a month, but there's a large concentration there, the sort of daily patterns. Sorry, I'm just taking a second to look at the question from Rachel. Yeah, see you, Rachel. So we also see high levels of use for marijuana or cannabis. Again, high levels of daily use, but also higher pops here for once a week or once sort of at that weekly pattern, but less than daily, right? So I'm reminded from that sort of Q&A coming through that if you got a question, feel free to pop one up in the Q&A. We do get notified because we're doing sort of more descriptive work here today. It's not a problem to sort of interrupt or pause if you see something unusual, or if you have a question about it, just kind of throw it up and we'll try and catch it, right? So our big takeaway here on non-injection substance use is that we are by far and away seeing methamphetamine and marijuana as being sort of our predominant substances, whereas opioids and especially heroin are really much rarer to find here in our participants. It's not a commonly used substance. It's present for sure, but it's much smaller amounts than you might expect from other states or what we see from the moment. So anonymous attendee asked, what are the specific research questions guiding this study? Broad question. The primary purpose was to understand substance use amongst people that are using drugs in this region, try and understand that over time. And we had a bit of a broad mandate there. That's why you'll see sort of a wide range of questions within this pattern. And part of what we also try and do is help other researchers work with people who use drugs when they lack that expertise, help them recruit from that. So we also ask questions that can help other researchers kind of find or understand baselines and things of that sort. So specific research questions are pretty broad on this. This was meant to be sort of a general understanding of what does it look like in Nebraska or this part of the country. We don't see a lot of research in this area. And so the goal was really try to expand on that and understand what's going on in a place with not a lot of studies and not a lot of research. Yeah, questions about fentanyl. It's not in the survey. It needs to be added in additional and later on. It would be a good one to see how people recognize that. We know that participants talk about it and are aware of it and are concerned about it, but we didn't have that initial category when we started. And it's one of the things we're looking at adapting as we move questionnaires further. And then specifically about counterfeit pills. So not initially. In newer versions of the questionnaire, we're asking more about prescription stimulants. And I believe Xanax is one of those. And it's, again, part of one of the things that we're sort of moving forward to. So when we started, a lot of these core questions are based off some of the national HIV surveillance studies and sort of started from that. And over time, we've expanded these out. So newer questionnaires are folding more stuff in as we go, right? So let me get back into this. So we also asked about these substances, sort of ease of access. One of these questions is always, well, how hard or how difficult are these things to get? And is sort of lack of different substances or different patterns of substances related to access here. And so basically we just said, how hard or how easy do you think each of these things is to get it? Sort of your own personal opinion. And we allowed a don't know option here as well. So the don't know is in gray. And then the left two bars are very hard. We sort of got this tan in the middle. It's either hard or easy, and then easy and very ease are sort of like the pink and the darker red. I apologize for the color scheme. When I got to this graph, I realized that my color scheme was not particularly conducive to bidirectional, but I tried to make it pop a little bit. And so what we see as far as substances being very easy to obtain is that marijuana is an extraordinarily easy substance to obtain for our participants. By the way, for those of you who are not familiar with the Nebraska context, it is completely illegal here. There is no medicinal, there is no recreational. We do have sort of that Delta 8 loophole here, as well as I'm sure many of you others are familiar with, and we're working to sort of fold that in the newer questionnaires and sort of get a handle on that. But otherwise, this is a substance that is still quite illegal here in the state, but extraordinarily easy for participants to get. Same with methamphetamine. There's a really huge bar there. So 66% of participants saying the methamphetamine is easy or very easy to get. What we do see is when we drift more into heroin or opioids or other opiates, is that we start to see more people say they don't know how to get these, or that these are more difficult to get, right? So if you look at heroin, 26% of folks are saying that this is a hard or very hard substance to obtain, where only 37%. Wow, wrong bar. That's cocaine. Where only 14% are saying that it's easy or very easy to obtain heroin, and sort of similar patterns with this, right? So at least for the folks that we had talked to, access seems to mirror some of the use potential as well, where these patterns seem to match a little bit. I see we got another question come through. Yes, Tracy would love to talk to you about counterfeits. And then, are there ways that you or others can use this data to advocate for increased harm reduction services for people who use drugs in Nebraska? 100%. And we've actually done some other data collection that feeds into that as well. We'll talk about it a little bit in a couple slides. But yeah, we have, we're trying to make data accessible as we sort of work through it, and get out in reports and make it accessible, get, try and draw news traction and traction for other people who are interested in sort of building on this data, have a sense of what's going on. In terms of harm reduction, Nebraska doesn't have a lot. And so sometimes this is the only information that's easily accessible, that's actually local and topical. So we are trying, yeah. So for access, this is sort of our overall picture, and it seems to match fairly well some of the things that we're seeing as far as patterns of use. Now, I mentioned that we had built some of this off of the National HIV surveillance studies, which sort of we had some expertise with from prior grants and saw it as a good place to start. And one of the things that they do is, because their focus is on HIV and routes of HIV transmission, is really split out substance use that works or is used with a route of admission of injection. Right? So we have a smaller subset of questions asking about participants if they've ever used a needle or to inject a drug and what different types of drugs we have. And what we found is that this is a fairly rare occurrence among participants here in Nebraska. 75 to 76% of our participants had never injected as a route of administration ever in their lives. And that for most substances, a further 20% hadn't injected as a route of administration even in the past 6 months. So that's sort of what we have here is this never injected column ever in their lifetime. The 0 times one is then the percent of people that, at once upon a time, they've taken heroin through a route of injection, but haven't in the past 6 months. But again, here, our exception is methamphetamine. We don't see it incredibly high, but we see that for the 25% of people, 24% of people that do inject methamphetamine, there's a reasonable percentage that are doing this on a daily basis. So about 8.5% or so of our participants report injecting methamphetamine daily. A further 6% or so report injecting methamphetamine once a week or more, so once a week to 6 times a week. And then about 8% saying once a month or less than once a month. The other substances that we asked about were fairly rare occurrences. We see a couple percentages further up. So the folks that do use heroin seem to have some injection patterns with that. But for the most part, it's not a very common route of administration here in Nebraska. But this does set up the next sort of question, which is, how often are people using new sterile needles when they're injecting these substances, when they're operating in this sort of way? And we find that 42% report that they always use a new sterile needle every time they inject. 38% though say most of the time, 14% about half the time, 3% rarely, sorry about the double percentages in there, and 3% never. So that 42% is great. That's the ideal. There's a lot of work to do here as far as to help people use sterile needles every time, or at least not when they're using with someone else. And so the second question over here on the right, how often did you use needles that someone else had already used? All right, this is that situation you really don't want to see, sort of that downstream effect. 71% say they've never done this, 23% rarely, 3% about half the time, 1% most of the time, and 1% always. So there's some work here to do, and this isn't surprising because syringe service programs are not legal in Nebraska, and there's no exceptions provided for their operation. So not only is it tagged as paraphernalia, but there's no medical carve-out at all for a syringe service operation to work here. The only sort of carve-out there is that pharmacists and pharmacy workers may sell syringes for non-medical use, but it's completely at their own discretion. So you have to hope that there's a pharmacist who's not going to give you crap, not treat you poorly, and that can be a risk, right? And then even if you did find that pharmacist who's willing to sort of do that, possession of syringes is still considered paraphernalia under Nebraska law, which means you could be right back in trouble. And the same reason you maybe only keep 1 or 2 stashed or you swap around versus trying to maintain a large supply of sterile needles so that those folks that are using or injecting on a regular daily basis can have that. So do we have a sense of where they source their syringes? Pharmacy, friend, dealer, diabetic street, et cetera. We didn't ask in this round. It's a good question to add. When I was putting this together, I realized we had sort of missed on that sort of sourcing question. So I'm not going to offer a guess. Other than that, it's something we need to add on. But good question. Because clearly there is a need to sort of track this to some extent. Now, the reason, of course, we're interested in sterile syringes is dealing with HIV and hepatitis C. So we asked participants in this round if they've ever been tested for HIV. 72% said yes. And the results of their most recent HIV test, 98% said negative, 1% positive, and 1% never obtained the results. They never went back to find out, or they've forgotten. And that's the option that they took in question. 66 or 67% had ever been tested for hepatitis C. 89% of those had been negative for their most recent test, 9% positive, and 2% never obtained results. When we were doing this work pre-COVID, we were also including sort of rapid HIV and hepatitis C tests as part of our protocol. And we largely found that those tests mapped on to what folks knew about their most recent HIV test. Since COVID, we had we didn't bring that back into the protocol because as human subjects research reopened in sort of the ongoing pandemic world, we figured it was risky enough just to have folks in shared spaces. We weren't going to start introducing sort of rapid tests as well. But this is something that we're looking at bringing back in our next phase, where not only can we ask about this, but we can also provide rapid HIV and hepatitis C testing for folks that come into our study. And I think it'll be really important to bring that back in and sort of provide this service, because there's still clearly a large gap for folks who haven't ever been tested. And we know that we really want, if testing as an intervention is to be a useful thing, it needs to be fairly common. You need to have some sort of confidence in that result and how things change if we're going to expect people to sort of adapt syringe sharing and sero-sorting behaviors on the way through. So sort of in line with this, we've been asking about overdose experiences. Those of you who are not familiar with Nebraska, Nebraska has been fortunate to have a low number of overdose deaths yearly. Typically, we range between 150 to 200, which compared to some of our neighbors is drastically smaller. But it is still fairly significant in Nebraska. And it's something that's been increasing over the past 6 or 7 years, as like the rest of the country, we've seen our drug supply shift. And sort of that range of effective to lethal dose has shifted with it. So we asked our participants if they have personally ever overdosed, and 23% of them had in their lifetime, and 5% had personally overdosed in the past 6 months. So it's definitely something that they're aware of personally. And they know people who have overdosed as well. 56% said they knew someone who had overdosed ever, and 27% said they knew somebody in the past 6 months who had overdosed. 45% of our participants said they knew somebody who had died from an overdose, and 21% had known somebody in the past 6 months. So this is something that they experienced personally, that they experienced those who were around them, and with that, the most severe sort of consequence where people that they know are dying from overdoses, right? So this is real, this is present, and even though we don't see huge levels of opiate use here, it's present amongst those who are using drugs. And we also asked if people had ever been present when someone else had overdosed, and 29% said yes, and 15% had been present in the past 6 months, which means that we also know it's really important to participants as well as sort of the general public know about Narcan and naloxone, right? Now, Nebraska does have laws that allow for free access programs for Narcan and naloxone through select pharmacies, as well as sort of a standing order prescription where you can go purchase them from any pharmacy without a prescription. But of course, that then requires the resources and the pharmacist not giving you a hard time, which unfortunately does happen. But we asked some baseline questions. So we asked participants, do you know where to get Narcan or naloxone if you needed it? And 48% said no, 32% said yes, and 15% said they don't know what it is. They were unaware of it. And then we asked those who know what Narcan or naloxone is, do you know how to use it? And 64% said no, and 36% said yes. So even just looking at this screen, there's a fair bit of work to do. And we do some of this with our participants. We provide resources on where can you go to get the free Narcan and naloxone that the state is providing? How do you use it? How do you use these resources? How do you recognize the signs of an overdose? How do you use this, right? And fortunately, we also have some Good Samaritan laws in Nebraska that should theoretically protect a person who's calling 911 or 911. There's a 7-Eleven down the block, it's in my head, who should protect people who call for help when an overdose is experienced or you're present during one, that should provide them immunity. But I understand the hesitation for wanting to do that. So really this idea of helping people be aware, feeling confident in how to use it, and being able to replenish is really key. And so there's clearly some work done here. And by the way, this matches, actually it's better than general population in Nebraska. We've done some work on this, and there's a lot of people in Nebraska, somewhere between 20 to 30% of just general population Nebraskans who don't even know what this is, much less know where to get it or how to use it. So this is a group that's showing a higher level of knowledge, which is what you would expect given personal experience and proximity within social networks. Sorry, I thought this was a Q&A question. Go up a second. So thinking about physical health, to some extent, this is thinking about, do you currently have health insurance or health coverage? 62% of our participants said yes to this, with most of them having coverage through Medicaid, some through Medicare, Very rarely was it employer provided, and there was a mix of other forms like people paying for their own programs or through the VA and things of that sort. But on the whole, only about 60% report having health insurance or health coverage, which then translates pretty directly into how recently have you seen a medical practitioner, right? So 53% say they've seen a medical practitioner in the last 6 months, another 19% 6 months to a year ago. That means there's a pretty reasonable size of folks who haven't seen a medical practitioner in the past year. And 6% of people haven't seen one in the last 5 years. And these numbers increase when we think about dental care, right? So only 21% have seen a dentist in the past 6 months, and then further 18% 6 months to a year ago. And 22% haven't seen or visited a dentist in more than 5 years. I see we have a new question up. All right, so we have an overdose question for you. What about stimulant overdose overamping? It's a great question, especially with our prevalence of stimulants. We didn't ask specifically about that, and I know the Narcan and naloxone is specifically towards the opioid overdoses. We didn't drill down on whether they think it was an overamp or an overdose through that opioid type. It's something that, again, we're sort of starting to build out our next phase of questionnaires that we want to push through. Partially because of the prevalence of methamphetamine here, but also, as I guess by your questions, you probably know, sort of that the presence of xylazine starting to show up in some of the East Coast and West Coast cities, and whether that's going to trickle here into the Midwest as well, because of the implications for sort of the use of Narcan and naloxone and sort of that first response and things of that sort. So not directly aware of it, trying to figure out how to bring it in though. That question box. Sorry, I clicked one too many times. So the lack of insurance definitely seems to influence this. When asked in general, would you say your health is? Most people are saying fair. Very few people say poor health. Only about 12% say that. 27% say very good, and 8% excellent. And I know this is kind of a funky looking question, but weirdly enough, it's pretty good for its associations with more formal health diagnoses. We asked directly about experiences of pain. In the past 6 months, 20% of folks said they'd never experienced pain. 41% experienced some days, 17 most, 22 every day. And for those who have experienced pain in the past 6 months, how much has that interfered with their life activities? 14% said no interference, 40% mild. But 26 and 20% said either moderate or severe interference with sort of their daily life and how that sort of interacts with their ability to do things and move around and just sort of exist. We also asked sort of some general symptoms. So 7% reported having a stroke, 36% high blood pressure, 6% heart disease, 13% diabetes, 5% cancer, and 5% liver disease. We have a question if these initial findings are published somewhere or publicly available. They will be as soon as this video gets put on YouTube is the answer to that. And then part of what we'll be working on towards next is formalizing this into publication, but this is sort of your first look at some of the stuff that we've seen so far. All right, so thinking about mental health. So I gotta watch my time a little bit. I think we're doing okay. So years ago, I wasn't directly involved. I sort of stepped into a project where they tried really hard to do full diagnostic disorders in sort of an interview setting. And they learned that you could just ask people to self-report their diagnostic disorder. And if they had it or not, it worked better than trying to figure out how to throw a 200 question questionnaire about major depression in that. And so we took that to heart and basically said, all right, let's just ask people to self-report. So keep that in mind as you move through this, but most people seem to have a sense, right? So we asked if participants, if they had been diagnosed with any of these, 46% said yes to major depression, 19% for borderline personality, 8% for dissociative identity, 35% ADD or ADHD, 42% for PTSD or complex PTSD, 51% for anxiety, 15% schizophrenia, 37% bipolar, and 16% an antisocial disorder. So we see a range of sort of options sort of popping up and some variants here as well. I think I at least was initially maybe a little bit worried that people might just sort of straight line their way down and just say yes to everything. But we see a good bit of range through this, and people seem to be taking it seriously when they move through this part of the questionnaire. We do ask a number of other scales, such as the Kessler-6, the Patient Questionnaire 9, the GAD-7, but I'm going to skip past those for this and just leave you sort of with the disorders as we sort of move into the next step. And so our second to last section is the ACEs, or the Adverse Childhood Experiences Scale. For those of you who are familiar, this was originally sort of really came to light through a Kaiser Permanente scale that asked essentially about 10 domains about things that might have happened to you when you were under the age of 18. And their goal was to try and sort of predict forward. We haven't done that prediction yet, but what I'm going to show you is essentially where do we stand for prevalence among our participants. Right? And so we have 10 domains here. And so 40% of our participants qualified for emotional abuse during their childhood, 28% physical abuse, 38% sexual abuse, 60% emotional neglect, 67% physical neglect, 34% witnessed some sort of or lived in a household with domestic violence, 61%, lived in a household with substance use. And so this is either illicit substance use or sort of egregious alcohol use. And then 47% lived in a household with mental illness. 46% had some form of parental separation, typically not including incarceration. So divorce, abandonment, separation. And then 31% had parental incarceration. So they experienced one or more parent be incarcerated. Our average participant had experienced 4 ACEs, which is quite a bit higher than we see in general population. And we had a standard deviation of 2.5 ACEs. So a whole lot of people were within that 1.5 to 6.5 range of ACE counts. And we did have folks that reported none. About 10% of our participants had no ACE experiences. But we did have some folks that had all 10. So about 41% had experienced 5 or more of these ACEs. 30% had 6 or more. 10% had experienced 8 or more of these ACE counts, sort of under the age of 18 when they were growing up. And our last sort of section here is sort of a little bit describe treatment experiences. Most of our participants had some form of history with a treatment program in their lives. So 49% had ever been in an outpatient program. 47% had tried an inpatient or residential program. I suppose tried is in quotes. Were in an inpatient or residential program. 37% in a detox program. 6% in a methadone or Suboxone program. This one's a little less surprising given the low prevalence of heroin and opioids, but it still seems fairly low. 35% in a 12-step alcohol program, 37% in a 12-step drug program, and 3% in some other type of program. We did ask if participants had been interested or had tried to get into a treatment program in the past 6 months. 12% said they had, but they had been unable to do so. So we sort of asked them a little bit of an open-ended theme or question there and said, okay, so you tried to get in, what happened? Like what happened there? And so a couple themes that come out of that is lack of transportation for the participants, or the inability to get there or to attend regularly. A lot of folks reported that there wasn't any space, or that they were placed on a waiting list for where they were trying to get in. Another common one was lack of funds or insurance coverage. Remember, a fair bit of people don't have insurance. And so even those that had would say maybe Medicaid wouldn't cover it, or that it wouldn't qualify for them. Some folks said that they weren't ready. They were sort of exploring it and decided they weren't ready for it. And other people, especially earlier on in this questionnaire, had some real concerns about COVID and what sort of that space would be like, and if going to treatment would essentially be also signing them up for a COVID diagnosis. So a couple closing thoughts. I know this has been a lot, and I tend to do minimal slides. So you've been staring at a bunch of numbers and hearing my voice for that. So a couple tail end thoughts on this. So first are some logistics stuff. RDS worked, but it took time, and it took some pretty reasonable incentives, and some incentives that we maybe need to up again. That interviews are taxing, right? So make sure you plan interviewer schedules accordingly. They need space, they need time. These are not necessarily easy interviews. So make sure you plan accordingly. Your interviewers are your most important resource. Without them, this doesn't work. So make sure you take care of them. Be ready to reschedule appointments. We do appointment only, and folks have busy lives, and you might be bouncing folks in and out a couple times until you find the spot that works for everybody. The other big thing on sort of logistics is trust. It can take a while for people to trust that this is not a trap, this is not a trick. And especially in Nebraska, where we really did have to start cold, there was no partner organizations for us to really work with. Early on, participants thought we were the police, or that they were a trick, and that maybe we weren't really going to give them money, or, you know, once they walked out the door, you know, we were going to call somebody and they get picked up. And it took a while for that to fade. And it seems like we're doing pretty good on that by now, but it's one of those things you always sort of have to deal with as you're working with new people, on even when they're coming in off of sort of friends' recommendations and learning about them. So give that time and work to sort of build that trust. About sort of some of the stuff we've talked about today as well, right? This high prevalence of homeless experiences. This is likely a network and an incentive effect. So I don't want you to walk away from this and think that everybody that uses substances in Nebraska is also really experiencing homelessness. I think this is a combination of us recruiting through social networks, and also that our incentive structure is more appealing to folks with lower income levels. And a lot of our folks are making less than $20,000 a year household. And that might mean more, and they might be more willing to take that risk to come in and try us out and see how that interview goes, right? All right, I'm going to come back to this last question in a minute about the CDC. So, oops. The other thing, and sort of based off this question about homeless experiences as sort of network and incentive effect, is that I want to caution you, and I want to caution myself too while I'm talking about this, is that these are simple descriptives. I've tried to keep this really simple because it's really easy for folks to sort of jump onto, oh, those things are correlational or causal, but there's no predictive work here yet, right? This is just dealing with the descriptives and trying to describe and have a sense of what are people experiencing so far. We're not, or at least not publicly, talking yet about the interconnections of some of these items. Some of them seem fairly clear, but that has yet to be determined, really. So I caution you to walk away from this with that. Then sort of is this final takeaway, right? So there's a couple clear trends that pop even from these descriptives, right? Which is that amongst the people that we've been interviewing, there's clearly a really substantial need for housing, right? That's just a huge amount of people that are unstably housed or are moving in and out of homelessness. There is a real lack of medical and dental care among these folks, as well as a clear need for more harm reduction knowledge, which we're trying to provide, and tools, but also that's something that at some point needs to be addressed at the state level. We need exceptions. This is something that needs to sort of be addressed. And then just thinking about the ACEs in particular, every time I go through them, I'm really reminded, we need some real care for trauma, both past and present. The level of ACEs and other sort of traumatic experiences that we see are just really, really high, and we need to take that into account moving through that. So I know there's a couple questions here. So before I get into that, a couple of these questions have been talking about sort of further things or other ideas, and we really are open to collaborations. We would love to work on collaborations with folks, so if you want to, get in touch with us. But also, more specifically, we're also currently looking to hire some postdocs, ideally two postdoctoral positions for 2-year terms who would come work with us on this data and some other center data sets that are focused around this. And we'd really like to have some awesome folks come work with us and work through this. The first review date is July 7, 2023. So if you know somebody or if you're interested, put an application in and you can find details about that here. And so let me say thanks and let's do some questions.